And it now gives me huge pleasure to both welcome to Washington, more formally for the Tele-Echo, even though she's been here for quite a while, Dr. Catherine Gordon, who's come now to live with us, so to speak, and be at NIH. And she's going to be speaking on bone health evaluation in growing patients. Children are not small adults, a topic dear to my heart. Catherine, thank you so much for being with us today.
Thank you so much, Laura, for the invitation. And thanks to everyone for coming. I'm going to try to share my slides here. Michael, I think you need to stop.
Sorry, one moment.
Okay. Yeah, the AV is always the trickiest part of virtual presentation. All right, let's try. Let's see. Okay, there they are. And what do they look like now, Michael?
We see your slides with the editing view.
Okay, now what about, did that change it?
Unfortunately, no.
Okay. We've been playing with this. I appreciate the audience's patience. We decided just to go forward, and I'll try to be extra entertaining to make up for it. How about that? So, listen, it gives me a great pleasure to be here today. Dr. Tosi and I have been friends and colleagues for a long time, working together on guidelines for children, and how to think about reporting bone density results in children, how it's different from adults, what we've learned from providers of adults that we can bring back to pediatrics. So I hope this will be interesting for you. It's a broad talk, but we see many, many patients here at the NIH who have a rare disease. In fact, I'm clinical director. I supervise the clinical research portfolio in the NIH Clinical Center. As some of you know, the NIH Clinical Center is the world's largest research hospital. Over half my portfolio are children and adolescents with rare disease. So it's excited to think about it together through that lens. So together, we're going to review pediatric risk groups for osteoporosis. So these are going to be infants up to even older adolescents, young adults. We're going to think about...
Dr. Gordon,
yeah.
I want to interrupt you briefly. Did you forward a slide? Because we were still on your first slide.
I did forward a slide, Michael.
Gotcha. We still see your title slide. Let me...
Wow.
I have your slides loaded right now on my computer.
Should we just do that? Yeah.
Maybe we just do that.
Okay.
I apologize to everyone if you don't mind just us doing the next slide. Next slide is better than no presentation at all.
I think so.
Yeah.
Okay.
So let me just give me a moment and I'll load those.
Okay. Yeah. So I even know some, just in the interest of time, we're going to talk about how to evaluate bone mass, two-dimensional measurement, volumetric, bone density, which is volumetric. Bone is a 3D object, so it's not confounded by bone size. And Michael, if you can just take me to the next. Yeah, there we go. So how do we evaluate bone health? DEXA, dual energy X-ray absorptiometry, gives us an evaluation of bone mass, which is what I was saying a minute ago, two-dimensional, and we're going to talk a little bit about how we get away from the confounding due to bone size, small bone size in children. We're then going to get into two tools that enable us to evaluate the peripheral skeleton, really important in children and adolescents because they tend to be running around playing sports, keeping Dr. Tosi busy because they're fracturing arms and legs instead of their hip and spine. Again, DEXA is going to measure the central or the axial skeleton. We're going to talk about some different models of pediatric osteoporosis, how we define it, and then consider what we know about management in this young group. So next slide, please. So I always like to start my bone health talks on any aspect of this topic with this slide. And this is bone mass on the y-axis and then age in years. And you can see between the ages of 10 and 20, the slope of the line is very steep, both in assigned males, assigned females. Over half the skeleton should be laid down during those adolescent years, accompanying growth, enhanced secretion of growth hormone augmented by sex steroids. A young person then reaches their peak bone mass, the highest point, highest measure of bone density for one's lifetime. And then unfortunately, over time, we're all going to lose bone, and more dramatically so in women because of the menopause. So as a clinician, something that I've done over the years is I'm often drawing a picture of this for patients, for families, talking about the bone bank. We're trying to do everything we can with nutrition and optimal weight-bearing exercise and keeping a disease under control, making sure there's consistent compliance with therapies to get to that highest peak bone mass, because we know that it's one of the primary predictors of future risk of osteoporosis. Next slide. So the rationale for densitometry in pediatrics is the same as in adults, but yeah, is there a question there?
Sorry about that. That was the TV in my apartment.
Oh, okay. Yeah, no worries. Just making sure you can hear me. The interpretation is where it gets trickier. The interpretation is much more complex in growing children and adolescents. Children, young adolescents are a moving target. They should be a moving target every time they come to the DEXA Center, NIH, or any other DEXA Center which I've worked. The bone should be bigger. The shape should be slightly different. And the positioning of a child can be more difficult, especially young children, than in an adult. The landmarks are smaller and again can and should change in size and dimensions, so it can be more difficult to replicate those measures. And we're going to talk about how that's informed which skeletal sites we've chosen. Next slide. So just to make sure we're on the same page, I've alluded to some of this. We have the central skeleton or axial, spine, ribs, pelvis, hips, shoulders, DEXA for those evaluations. And then we have the peripheral skeleton, which is arms and legs. Again, very important in pediatrics. And we're going to talk about what standard peripheral quantitative computed tomography can give us, help us with, versus the dream machine, I call it high resolution PQCT, how it's different and how it's advancing the field. Next slide. So what skeletal sites should we measure in a child or an adolescent? So they're influenced by age. So in a 4 to 15-year-old, I'm starting with 4, we know we have robust pediatric reference data for 4-year-olds and above. That's not to say not to ever get a measurement in a younger child. There's growing reference data even in infants. But 4 is an age where the wiggle factor is usually less, where a child is not as scared coming into a DEXA unit. So within that age range, it would be total body. And in fact, if you have the software, total body less head, and then the lumbar spine. The lumbar spine is our easiest. It's our old friend. It's easy to line up a child. It's easy to replicate those measures. The reason, as funny as it sounds, we take the head off, we take the skull off, is the skull is 40% of our total body bone mass. And the skull is also dense cortical bone, where it's not apt to change. Most of us are not standing on our heads, a lot at least. Sometimes we feel like we are, but we're not standing on our head and doing something that's going to weight bear on the head, as funny as that sounds. Or if we give a medication, it's not apt to affect that skull bone density, whereas it is likely to affect other parts of the body. So we take it off whenever we can. And the reference data has both total body less head as well as the total body measures. Next bullet, you advance. When an adolescent gets to the age of 16, so 15 to 16 is where we start to transition. to the hip and spine. So those are going to be the measures that we follow that our adult counterparts, adult specialists, subspecialists are going to be following. But I would recommend, and ISCD recommends, a one-time all three sites, total body, spine, and hip, so that you can look at the rate of change from those childhood measurements and then get that baseline hip scan. And we're going to talk about why you're probably wondering, well, why don't you just do hip and spine throughout the lifetime? There are advantages of that total body scan, and the hip can be more problematic in children. There's one more bullet. And there's some special considerations which I'll talk about. Occasionally we'll do a hip in a younger child if we're not able to do the standard skeletal sites. We'll do a forearm scan, the distal third radius, or in a child with contractures where it's difficult to position for those other scans, or if they have an orthopedic rod in place, we would recommend a bilateral distal femur. Next slide. So let's talk for a minute about DEXA. DEXA is safe, it's fast, it's precise, it's low cost, it's widely available in many of our even health centers, certainly hospitals, for measurements in children, adolescents, and adults. It's the same machine, but it's just important to make sure that when you're scanning a child that you're using pediatric and not the adult software. It's the preferred method for assessing areal or two-dimensional bone mineral density, or BMD, and the PA spine and the total body less head are the most accurate and reproducible sites for performing areal BMD measurements in a child. But other sites may be needed depending on the clinical need and that scenario, as we'll talk about. Next slide. The lateral distal femur and the forearm are alternative sites. We've got reference data in pediatrics for both of them now. In fact, there's a lot of interest in the forearm because the forearm is such an easy measurement. Children are generally not scared to put their arm out and position it. It's fast. It's somewhat like getting a bone age. A lot of them are used to that. And then the lateral distal femur is ideal for children with disabilities. A lot of children with rare bone diseases, maybe non-ambulatory, for example. So it's easier to comfortably position them with cushions to measure both distal femurs. And cerebral palsy with contractures, Duchenne muscular dystrophy, and Rett syndrome is another example. I've had many patients I've followed with Rett who have a movement disorder. So it's easier to get a scan of the distal femur and not have to worry about the motion artifact. Next slide. Whole body assessments, very helpful in children, especially those who we care for with a chronic condition. They can also be helpful in adults with chronic conditions. So I'm not saying never get a whole body scan in an adult, because if you're interested in body composition and how it may be changing as part of a natural history study or with respect to an intervention, it's something that I use commonly, certainly here at NIH, and have used at academic centers in my clinical practice. Whether you ask for it or not, that total body scan is going to come with body composition too, so it doesn't have to be a special order. And the compartments, the variables that I have followed have tended to be the fat mass, the lean body mass, which is a surrogate for muscle mass, and then the percentage body fat, especially helpful in adolescent girls, where I might be monitoring their estrogen status, their menstrual status as well. And I just wanted to mention it. As you read the literature, you'll see that some studies look at the bone mineral content in grams. It's calcified, so the calcified area of the skeleton, it may be slightly less at risk for the confounding due to the two-dimensional DEXA measurement. But again, if you see that in the literature, you can certainly follow that along. In general, in my clinical practice, I just follow the absolute bone mineral density in grams per centimeter squared, and then the accompanying BMDC score. Next slide. So the hip, I've been talking around the hip. The hip is not a preferred site in growing children and teens due to variability in the skeletal development. So skeletal landmarks which guide the positioning, again, may not be well developed. The greater trochanter is an example. It can be difficult to see it in a young child, and it starts popping up more and more, that then guides our technologist as he or she tries to get those replicated measurements exactly in place. Errors can develop. The position and placement of the region of interest using the standard software, one might be comparing an apple and an orange, again, depending on the positioning. So there's lower precision of measurements at that site. However, if you have a spinal rod in place, or there are other reasons where you can't do the standard sites, this is not to say not to do a hip measure. The hip is primarily cortical bone, and it can be helpful to have a cortical rich and a trabecular rich site. A trabecular rich, an example, would be the spine. But stay tuned. The Bone Mineral Density in Childhood Study Group, NIH-funded initiative over 5 different sites. They've done a lot of work with the hip and have come out with some new normative data. And it's especially helpful for those children who we might scan. Next slide. Very different from the diagnosis of osteoporosis in adults. We should not make this diagnosis based on densitometric data alone. I always say to my residents and fellows, we're going to treat the patient and not treat the DEXA scan. So the diagnosis of osteoporosis in a child requires both a history of a clinically significant fracture, the type of fracture, pathological fracture, the multiple fractures, and a low BMD. And how do we define a clinically significant fracture? Michael, if you could bring my bullets down. A long bone fracture of lower extremities and or vertebral compression fracture, that's always a pathological fracture, or 2 or more long bone fractures at the upper extremities. The reason you only need one lower extremity fracture, the lower extremities in a child who is walking, is ambulatory, they should be denser than the upper extremities. So even one lower extremity fracture, I'm going to be worried about that child from a bone health standpoint. Any child with a vertebral compression fracture, same in an adult, where that's always a pathological fracture, or 2 or more fractures of the upper extremities. And low BMD is defined as a BMD z-score of less than or equal to -2, adjusted for age, for gender or sex, and body size as appropriate. And we're going to talk about how height has emerged as a very helpful adjustment. Next slide. So this is an example of a DEXA scan. This was a patient I followed with anorexia nervosa. In general, we measure L1 to L4 of the lumbar spine. Michael, if you can click one more time. If we were together, I would say, is this low? And of course, she would say, yes, it is. It's -2.5 because she told me that the threshold for a low BMD in a child or teen is -2. And it's important to know that up to the age of 50, now, so age 4 up to 50, we should be using BMD-Z scores, or that's what ISCD advises that we use, International Society for Clinical Densitometry. And importantly, in a child or an adolescent, we want to ignore the T-score. The T-score takes the bone density from that day and compares it to what's assumed to be peak bone mass at the age of 20. So it's assumed that 99.9% of young adults are going to reach that peak by 20. If a child is 8 and you're looking at the comparison to 20, of course it's going to be negative. And some of you have heard me say this. I feel like too often I needlessly become a hero when I see a child and we rescan them and we calculate the Z-score and we find that the skeletal deficits are not that severe. Next slide. Height is always important to consider. Height is always important for any child we see, especially those with rare disease. And it's an important measure to look at, especially with follow-up measures. So has the child grown or not? Also, did they gain weight or not? Because sometimes that helps us to understand changes in body composition and either gains, reflecting bone accrual in a child, lack of accrual, so steady state, no change, which would also be pathological in a child, or in rare cases, bone loss. So we're the most concerned, of course, about that. But in a child with short stature or with growth delay, the spine and total body less head results should be adjusted. One more bullet. So for the spine, we can either use an equation that gives us a guesstimate of the third dimension of bone. It's called bone mineral parent density, or we can use the height z-score. And for total body less head, we can adjust using the height z-score. So where do I get the height z-score? We typically use I know we have an international audience, the US CDC, Centers for Disease Control and Prevention, has curves. And so for a child's age and their height at that day, we can get the height z-score. And then Dr. Babette Zimmel and the BMDCS collaborators put together a wonderful applet that's online. It's a calculator where you put in the child's areal BMD for that day, their height, their age, the date of the scan, and then you can get a height for age adjusted z-score. That height seems to be the most important variable in adjusting for the confounding due to the two-dimensional DEXA measurement. And you can just go online, you can put in Children's Hospital of Philadelphia and bone density calculator, and it will pop up. It's very easy to use. It's a wonderful resource. Next slide. So again, this was just to remind you about the applet. Years ago, this was from 2010, Dr. Zimmel started looking at BMC and height, and she generated the reference curve. And this was the forerunner to the calculator that she later developed. And in many DEXA units, if a child has short stature, we'll report the chronological age z-score and then the height adjusted, and we will follow those over time. Next slide. In selected clinical situations, we will also consider adjusting bone density for bone age. And the one time that I do this are patients with delayed puberty or who have multiple hormonal deficiencies. Patients with CNS tumors, they have panhypopituitarism. As an endocrinologist, I'm adding back many, many different hormones. And the bone age adjustment can be helpful. And most other groups, I use the height for age z-score adjustment. Importantly, all of these, it avoids the overestimates of skeletal losses if the bone age is delayed. So if we have a 14-year-old and they have a bone age of a 12-year-old, we're going to trick the DEXA scanner. We're going to change the birth date so that it thinks we have a 12-year-old, and then it's going to generate new z-scores, which are higher. At present, there are no published reference data relative to bone age, but I know it is in the works from groups out in the field. And again, this is best practice in my mind for that child with hypopituitarism. Next slide. So how can we use lean body mass? So adjustment of BMD for lean body mass is again a surrogate of muscle mass, is useful in determining if a child's or an adolescent's primary abnormality is within muscle, within bone, or a combination. And it's also useful to note changes over time, even in the absence of an adjustment. Next slide. So I want to talk for a minute about the muscle bone unit. There's a high correlation between muscle mass and either BMC or BMD in youth and young adults. And multi-stage algorithms were established many years ago. You can see these are older references, but these are the classic references that have shown multiple times now DEXA data relative to muscle mass and how it can help us to understand what's going on with that young patient. Next slide. So all of these algorithms establish 4 diagnostic groups. I think it's helpful to think about a normal situation is where the muscle force is adequate for height and the BMD is normally adapted. So there's that normal tug of muscle on bone. Weight bearing is important. We know now there are a lot of signaling factors between muscle and bone, and they're working together. It's a healthy unit, that healthy muscle bone unit. A primary bone defect is like a child with osteogenesis imperfecta. Their muscle is adequate for their height, but the BMC or BMD is much lower than expected for the muscle force. So this tells us it's from that mutation in the collagen gene. There's something intrinsic to the bone that explains why they may have a low DEXA measure. A secondary bone defect example would be SMA or Duchenne muscular dystrophy. The muscle force is low for the height, and the BMC or the BMD has adapted adequately to the decreased mechanical load, but we still have a low bone density. So it explains, if you will, why the bone density is low, and it's from that lack of a healthy muscle bone unit. And then lastly is a mixed bone defect where the muscle force is low for height. The BMC, the BMD is even lower than expected for that reduced muscle force. An example are adolescents with anorexia nervosa who have a very distorted body composition, and then there are hormonal factors that lead to ongoing low bone formation, increased resorption, and a low BMD as well. Next slide. There are curves I just wanted to show you and to hint at what we're doing in my lab at NIH. Several years ago, 2011, when the BMD-CS was published their reference data and they compared it to the pediatric NHANES data at the time, they noted an interesting observation that the children and adolescents who self-reported being Black had a much higher bone density than everyone else: white, Pacific Islander, Asian, Hispanic. And so the way the reference database is set up is a dichotomous Black and non-Black. And over the years, in trying to publish data and mentioning the BMDCS reviewers, and sometimes when I've given talks like this, I've gotten many questions about that setup. And my lab at NIH has been trying to understand what race may be capturing. Is it skin pigmentation? Is it genetics? Is it both? We've published some preliminary data and are still looking at that, doing a deeper dive with skin pigmentation using spectrophotometry, a device to look at skin tone and seeing how that correlates with self-reported race. It's also really important to recognize that our communities are increasingly diverse. So a child of mixed race, it would be much better to have a quantitative measurement and then to think about normative data by skin tone rather than by race. To be continued. I hope I have the invitation to come in a future year and I can show some of our findings. Next slide. So how do we report bone density? So first of all, the term osteopenia should not appear in pediatric DEXA reports. The definition varies depending on who you ask. If you ask a radiologist or an adult bone specialist or pediatric, it just generates confusion. So in general, avoid that term. As I told you, the term osteoporosis should not appear without knowledge of a clinically significant fracture history. And then we talked about -2 for the Z-score being the threshold of concern. And again, T-score should not be used in a pediatric report. Next slide. Other information, they're different manufacturers of DEXA scanners, so reporting which, and they're slightly different, so reporting which type of machine, the model, the software. So if you see a child from the outside, you know how that measurement was obtained, and comparing it to which what DEXA scanner your center has. Who's the referring physician? We always want to communicate the results back. The age, the gender, the race, ethnicity, the weight, and the height. Relevant history, for example, have they fractured or not, their lifetime fracture history. The indication for the study, that can be helpful to the person reading the DEXA scans. If you have a knowledge of their pubertal history, their Tanner stage, bone age results, if you have a comment on the technical quality, whether there was motion artifact, whether there was a umbilical ring or something that you could see that led to the exclusion of a vertebrae, just throwing out examples. And then reporting the absolute or the raw BMD accompanied by that C-score. Next slide. The baseline report should have the source of the reference data. For example, the BMDCS is what I always have for reports coming out of NIH here. Did I make any adjustments for growth for the HAZ, the height for age Z-score adjustment, or for bone age? My interpretation, was it low, was it not? And I will mention in a child with a rare disease, an ongoing disorder, ongoing threat to bone health, if they're between -1 and -1.9, sometimes I will classify that as slightly low. I have them on watch because I'd like to see them in a year or two to make sure they don't cross that -2 threshold. And then I give general recommendations. In general, when I'm reading DEXA scans, I haven't met this patient. So I'll give my recommendation, for example, the clinician might consider a repeat measurement in 1 to 2 years. In a clinical setting, we would not get DEXA scans more than annually, sometimes every 2 years. However, in a research study, we often will do a bone density every 6 months. DEXA scans every 6 months, same with PTCT, so that we can monitor for changes. Next slide. I want to now transition to other modalities, this time for assessing the peripheral skeleton, so peripheral QCT, which provides a 3-dimensional measurement and allows us to look separately at the trabecular and the cortical bone compartments. Looking at the tibia or the radius on a cross-section, we can also gain insights into bone structure and cross-sectional geometry and some estimates of skeletal strength. You can see it's an open gantry. It's rather small, so you don't have to find a huge room in your center to house it for patients to come in. And then the computer is connected to the scanner, so just thinking about it's a web-based system, just knowing that you have to have room for that monitor as well. Next slide. I thought I would share with you some work I've been doing for over 20 years on children with progeria, Hutchinson-Gilford progeria syndrome, rare, actually an ultra-rare disease. We see it in 1 in 4 million children, and it's associated with the appearance of accelerated aging. They have a strikingly similar phenotype as you see from these photographs, but they have no developmental delay or cognitive deficits. They have a striking growth delay that we start seeing at 6 to 12 months. And so they look much, much younger than they really are, and being cognitively normal, it's quite difficult for these patients. There's a mutation, as some of you know, in the lamin A gene. That cryptic splice site results in normal lamin A being formed, but also an aberrant protein called progerin, and it can lead to nuclear membrane distortion and other skeletal defects. And I've been part of a clinical trials team working with Boston Children's, testing chemotherapeutic agents to try to prolong their life, and happy to say that this work resulted in an FDA indication a couple of years ago, which is prolonging the life of these children for 6 or more years, but we're still at it. Next slide, please, Michael. Just highlighting progerin. So what was interesting, we were getting DEXA scans as part of the clinical trial, but also wanted to look at the effects of our intervention on the peripheral skeleton. It was hard to get a weight-bearing site. In general, I like to look at the radius and the tibia, non-weight-bearing and a weight-bearing site, but because of their contractures, it was difficult to get the lower extremity into the gantry. We also knew that children with progeria had, by previous reports, aberrant mineralization, so kind of a wavy look, pockets of dark and light spots, and we wanted to understand that more and see if it appeared in the peripheral skeleton as well. So from the growth plate along the radius, we looked at 4, 20, 50, and 66%. And we're interested in the bone density, and we looked at our skeletal images, and lo and behold, you can see the healthy control on the left. This was 20% from the distal growth plate. And then the patient with progeria, HGPS, had a star shaped to their bone. And then at the 66%, moving up from the rest, we could see a hook compared to the cylinder. So it was interesting, even though in the study we were going after volumetric BMD, we learned so much about how progerin distorts the shape of bones in these children. And they also have these interesting extracellular calcifications as well, as you see on the photograph and then radiographically. And happy to take questions on that in the Q&A. Next slide. Many centers are now moving to high-resolution PQCT. Happy to say we have one now in the clinical center. We're one of 28 scanners in North America. It provides a virtual bone biopsy. So like standard PQCT, we can look at the cortical and trabecular compartments, but we can get great insights into microarchitecture. It's a much larger machine, as you can see in the photograph. And then this is just a taste of the images where we can see the denser cortical shell and then the trabecular bone and really how it's woven together. We can even see where it drops out in patients who have osteoporosis. Next slide. Also wanted to mention, similar to standard PQCT, we try to look at the tibia to get a weight-bearing site, and then also the radius non-weight-bearing. And like PQCT, we can look at volumetric bone density and also get estimates of skeletal strength. However, the resolution is much, much greater with HRPQCT, as the name implies. And one more slide, Michael. We also can do what's called microfinite element analysis. And so we can generate color maps, as you see on the slide, that look at the predicted strains in bone as it's loaded in compression. So it gives us a map of where the stress points might be to help us understand fracture. This is a relatively common condition in adolescence, but something I'm excited about is the work that's being done with stress fractures. These are adolescents who come to a practice, they're fracturing bone, they often have a normal DEXA scan because they're weight bearing so much, but I think it can help us kind of figure out that missing link of how the bone is structurally different. And I think we could apply it to many rare diseases as well as part of our natural history studies. Next slide. I've also been interested in bone marrow composition using MRI and MR spectroscopy to non-invasively look at marrow composition. As we all know, they're progenitors of osteoblast and osteoclast within marrow. I've been interested in the progenitors of osteoblast and how the hormonal milieu impacts them, and adiposity, the amount of fat within marrow and how it's linked to peripheral and axial bone density. I've been looking at it in a number of models, anorexia nervosa and actively now inflammatory bowel disease. By MR spectroscopy, and you can see we're assessing at the knee, at the distal femur. We can also look at peaks of water, but also
Catherine, we've lost volume. We've lost sound.
Just wondering, Michael, if you can hear me.
Now we can. Thank you so much.
Yeah. Okay. Perfect. I'll try. I don't know. Maybe I'm getting a low signal here. Yeah. Next slide. I'm about to finish up, Laura. We also, importantly, don't forget your high-tech tools, your growth charts, and correlating them with the rate of change curve to the right there with DEXA scans. They should be going in the same direction. They should be going in a positive direction, positive slope in a child. This rate of change curve and to the right is very concerning and not in sync with the growth chart. So don't forget about the growth charts. Next slide. So growth, puberty, and bone accrual should go hand in hand if they start to flatten out. And this was a child with celiac disease, weight before height, and then there were skeletal deficits as well. Next slide. There are many at-risk children and adolescents, next bullet, many which are models of malnutrition and bone loss. The ones that are highlighted, and Michael, if you hit there we go. The ones that are bolded are ones that my research team has been thinking about, but they're feels like too numerous to count sometimes. If you think about a tertiary care hospital like Children's National, who are our pediatric partner, there are many children and adolescents who may be at risk for a low bone mass, and also many of our children with rare bone disease or rare diseases that can be associated with bone loss. Next slide. Important to take a history. Did they fracture? Exactly what happened? Was trauma involved? Do they have hyperextensible joints? That may be a type of OI or Ehlers-Danlos or other disorders. Is there a family history of multiple fractures or osteoporosis? 75 to 80% of bone mass is dictated by genetic factors. What about teeth? The dental history. Remember, our teeth are bone. It's the only part of our skeleton that we can see, and often there can be abnormalities in teeth, as we all know. OI is an example where there might be dentinogenesis imperfecta, again, just as an example. We've talked about the importance of thinking about the growth, pubertal development, and regular menses in an adolescent girl. Are they irregular or have they stopped? Might that be a sign of estrogen deficiency? What about substance use that can affect bone turnover? Taking a detailed dietary history. I mentioned that many of these chronic disorders can also be associated with malnutrition. What about activity? No activity or too much activity, like my patients with eating disorders who are hyperexercising, medications that may be affecting bone turnover, and then the chronic disease itself. Next slide. I'm almost done here. And this gets us to my cases. So, Laura, I'm thinking should I go through a case or should I let you make announcements or?
What we would do is take a short break.
Okay.
I can do my announcements.
Okay.
And we also have a question in the chat, and then we'll come and do cases.
Okay, very good.
Alrighty. So, Michael, if you would switch the slides. That was wonderful. Thank you. What a great review and summary.
Thank you. And thank you for your contribution to the guidelines. Much of what I mentioned today, Dr. Tosi and I were part of an ISCD reporting clinical practice guideline committee. So thank you for that.
Important. I'm so glad they finally added forearms. All righty. So next slide. If you're on, please be sure that you've signed in. Save Michael tons and tons of time. And we'll be putting up the red cap sign in just a minute, because we love to give you the free CME. Then next month, we will have Mike Kelly and also Mike Dellinger talking about some updates on Gorham Stout, one of my toughest disorders. Next slide. And don't forget, we have a separate OI tele-echo, and they'll be doing assessing and quantifying pain. and that will be on May 14th, so just 2 weeks away. Next slide. Then I think and hope everyone knows about our OI and rare bone disease clinic town halls, but we want to be sure that we're sharing updates with your entire staff. And we have a particularly exciting town hall coming up on May 29th. We'll be discussing basilar impression, pregnancy, some recent adult fracture data, lots of things that are happening and important to be up to date on. So please join us then. Next slide. And, timing is always difficult. And also, now that COVID's over, it's fun to get together. In Washington, we have the Metabolic and Rare Bone Disease Club, but we do it both in person and on Zoom to be sure that folks can share our good speakers. And in June, we'll have Jenny Miller talking about ENPP1 and ABCC6 deficiencies. We'll be focusing on XLH in September, but a slightly different perspective than we usually do, which will be from the nephrology and rheumatologic perspective. And then November will be focused on achondroplasia, so stay tuned. So please sign in and get your CME. And now let me just take a minute to go to the questions. Righty. So from Anna Ryabetz Leinhardt, thank you for discussing height-adjusted Z-score for bone density. Are there opportunities to build in height correction into the DEXA software?
Yes, yeah, Anna, thank you for that great question. I hope so. Is there anyone from Hologic or GE? We use it mostly for the Hologic systems, but I think it's a wonderful idea. What I've had to do, every academic center at which I've worked and here at the NIH Clinical Center, is to have our technologists manually go in and use the calculator, and then we report both. As I said in my talk, I'll report the Z-score for chronological age and then also height adjusted. And then when a child comes back, I report out both ways, so I'm tracking them. Often I see if a patient with celiac disease, for example, their bone density gets better and better if they're compliant with the gluten-free diet, and that short stature goes away. So the height adjusted and that for chronological age, they get closer and closer together over time, which is also nice for us as a clinician caring for the patient, and nice to be able to share that data with the patient and their family.
I have to laugh, Catherine. You're very lucky. Your technician does that for you. I confess I have my iPad right there, and I'm going to the CHOP calculator, and I have to just do it myself. And it is time consuming when you're running a clinic, so it would be lovely if that could happen.
We're all going to vote for that good idea, Anna. So thank you for that.
And then Haley Wasserman asks, could you speak to concerns about a height adjustment in extreme short stature and whether it overcorrects BMD? Any guidance on when to not height adjust?
Yeah. Hi, Hallie. By the way, thanks for that good question. I've tended to correct for all short stature, what you're getting at extreme, but also just slight short stature. One thing that I didn't mention, I've been asked sometimes if a child comes in who's tall, do we then correct then? So their Z-score, as you know, is going to be lower than it was for chronological age. So I appreciate the question and have not done that to date, but that's something that we should be thinking about. So thank you.
Well, then Jessica Hansen brings up something I was totally unaware of. Has anyone else been dealing with the FDA recall on Hologic machines? We've been told that they can interfere with implanted devices. I have been told that we are unable to scan patients with implanted medical devices, such as shunts. I got a lot of those. VNS and baclofen pumps. How are you handling these patients? We do not have another DEXA for a pediatric patient.
You know, that's the beauty of these bone echoes, right? To share. I had not heard that, Jessica. And yes, we do have patients, especially with the baclofen pumps. So I'm going to have to look into that. I don't know if anybody else wants to shout out if they've come into that problem in their units and what they're doing. But I appreciate the situational awareness on that.
Jessica, who notified you? Can you please unmute?
Hi there. We were informed by our radiology department. We finally, actually, in the last month or two, were able to look at the paperwork that they received. And it is an FDA recall for Hologic machines with certain serial numbers. And unfortunately, our machine was one of those. And I'm in Nebraska, and we have the only pediatric machine in the state. So we have numerous patients, complex patients that have these implanted devices. So now I feel like we're flying blind with some of these patients because many of them are, already on treatment with bisphosphonates. So yeah, I'm just curious if anyone else has been dealing with this.
Do you have an older machine or a younger machine?
It was replaced about 2 or 3 years ago.
Really? Wow. Yeah, that was my thought too.
Oh, Dr. Velasco showed the link here if you guys are interested.
Yeah, great. No, thank you so much. I will look into that.
You are ruining my day, but thank you.
Yeah, and no, it's really that's really problematic, especially in a more remote area where it wouldn't be easy just to go across town, right? And it's interesting that it's just the Hologic system or a model.
Yeah. All righty, keeping going. Anna came back and said, thank you again. What are your thoughts about advanced bone age in children and effects on BMD assessment?
Yeah, so you can somewhat like the tall child, you might be overestimating. In general, I rarely use the bone age correction anymore. I used to. Now that we have the calculator, it's easier. I don't have to get my technologist involved. Again, my technologist will do it if I tell her to at the time, but sometimes I think about the correction. I recognize the short stature when I'm seeing the patient, so I have to do it manually. The bone age correction, you need to go back to the scanner, change the birthday. The time I've found it to be the most helpful, again, are those patients with panhypopet. And I can see here if a patient with panhypopet is very short and has delayed bone age, would you adjust for both height and bone age or one or the other? It's not wrong to adjust for both. It gives us more information. I've tended to choose one. And if it's easier to do the HAZ, the height for age adjustment, you could do that. A lot of patients, at Boston Children's, Dana-Farber, the cancer center was right next door. So when they would go to the DEXA center, they came with their bone age as well. And so it was just every couple of years we would have it done. So I think my answer would be to pick one or the other, but then to track it consistently.
Okay. We've got the link right.
So
Okay.
There's some other people doing it themselves. I see, Laura. So you're in good company.
I'm right there with you. That's great. All righty. So let's move on to cases.
Okay.
Great.
Michael, I may rely on you again so we don't get into
no problem.
in Wonderland.
Let's make sure we're on the right slide as well.
Yeah, that's it.
Perfect.
Very good. Yep. So we'll start it there. Again, I wish we were in the same room together so I could write things on a whiteboard and have you guess. So these are real patients I've seen, and then I'm going to open it up and have you share some cases with me. This was a 15-year-old with galactosemia, and she presented with a history of amenorrhea with no menstrual period for 6 months. Her menarche, or first period, was at 13. and she had regular periods until 6 months ago, so they really just stopped. And the patient asked a lot of questions, had no change in her weight, her diet, or eating, or exercise, or other lifestyle habits. And there was a negative family history on any front. In fact, there was a negative family history for osteoporosis, multiple fractures, and also for an eating disorder. That stopping regular periods and then stopping made me wonder, was she worried about her weight? Had her diet changed, or was she exercising more, or both? But it was negative. And one more bullet, please. So I did some laboratory testing, and lo and behold, so I wanted to think about her estrogen status. So on physical exam, the vaginal mucosa looked like she was poorly estrogenized. And so, but I have been reassured by my history about this being hypoestrogenism in the setting of an eating disorder. And so I was thinking, is her thyroid normal? Is her prolactin normal? And what about her FSH? Where her FSH came back at 88. Very elevated, and she had an undetectable estradiol. And then I asked about her fracture history. By the way, Dr. Hallie Wasserman has been my collaborator and is now a world expert on this diagnosis. The patient had a history of 2 long bone fractures. So there you go. But they were upper extremities. Next bullet. So what other questions would be necessary to assess bone health and the risk of low bone density? So we could go back to my slides and ask a lot of detailed questions. Some of them are in this vignette at the top. Did she have delayed puberty? Were her periods ever regular? The lifestyle issues we've talked about. Would want to know a lot about fractures, about medications, about chronic diseases. So one more bullet. Did she undergo a DEXA scan? Yes, she did. With even the amenorrhea for 6 months, she would be a candidate to have DEXA screening. And then we'd be asking, right, does she meet that critical threshold? So, or is at least one of the Z-scores equal to or below -2? And the lowest BMD was at the lumbar spine, rich in trabecular bone, often the one that is at risk in patients with amenorrhea. It was -2.4. More bullet. And did she have fractures? So were the fractures clinically significant? So I told you she had 2 bone fractures and need to take a detailed history as to what happened. What was she doing? Was she playing sports? When I lived in New England, a lot of my patients would slip on the ice and they break their arm. And if you slip and fall with momentum, probably any bone could break. Or was it she was on the grass, lightly jogging over to the swing set and broke something? I believe I have one more bullet here. So more extensive laboratory testing would be needed. So next slide. So what would that be? So we have an adolescent as a BMDC score of -2.4 at the spine. That's the lowest BMDC score. So I'd want to check her vitamin D status. I'd like to get a CBC if I don't have an explanation. So this would be the child coming in, not sure what's going on, or maybe a child carrying a rare disease diagnosis and want to better understand. It may not be classically associated with a low bone density. The CBC is helpful in all children and adolescents with chronic disease, but you also want to rule out leukemia, because I've seen a few children or adolescents who presented me with their marrow infiltrated with cancer. T4 and TSH, the reason you want to get both is you could be falsely reassured in a patient with central hypothyroidism by a normal TSH. A calcium, a PTH, I'll get a total ALK phos just from a metabolic panel as a marker of bone formation. And if it's high, it might be reflecting rickets. Again, depending on the patient, this patient, I checked the estradiol, the FSH. Usually FSH is enough, but not wrong to get an LH as well, and then a prolactin to make sure she didn't have a prolactinoma or prolactin elevated in the face of another CNS tumor. And I used to have a celiac screen as the second tier workup, but now I always get a serum TTG and a total IgA. It's an IgA-based test because I've been humbled by celiac disease over the years. I've had patients who are completely asymptomatic, who, from a GI standpoint, who present to me with a low bone density or with frequent fractures, and lo and behold, they have active celiac disease. The bottom of the slide is more situational. So I will often get a spot, calcium to creatinine, urine calcium to creatinine. If it's elevated, I'll proceed on to a 24-hour urine. If I have any cushingoid signs, I'll get a 24-hour urinary free cortisol and or a morning cortisol. The bone biomarkers are generally reserved for research because they're very elevated in children and adolescents. They're growing, and the markers reflect that, and how high is too high is a matter of debate. So I just reserve those for research, and a bone age radiograph, as we've talked about, if there's pubertal delay. All right, next slide. I would show you an example of a DEXA report. I told you the features that I put in a report. So this was a teenage girl at risk for low bone mass, and I'm presenting really some general principles, and they could be used for a child with a rare disease or any chronic disease. So this was a patient of mine who had Crohn's disease who was referred for screening. So she had a BMD performed on a hologic Discovery A scanner many years ago. As you can see, this was back when I was in Boston. And I have her date of birth, so we can calculate her age. I have her height, I have her weight that day. Really important to document that on the baseline DEXA scan. So if she comes back, I can see, has she grown? Has she gained weight? Has she lost weight? I knew that she had Crohn's disease. I knew that her gastroenterologist wanted to do a screening test. There was no history of fracture. There was no family history of bone disease, osteoporosis, etc. So you can see what we got. A lot of the reports are going to give you a Z-score and a T-score with that absolute BMD. But one more click, Michael. But remember, I told you to ignore the T-score. That's what's tricky. It's on the report often anyway, but ignore it. For child or adolescent, we're just going to think about the Z-score. And the Z-scores, I'm sure you would agree, and I wish I could see you all in the audience. It's reassuring. It's far above -2, and above -1, as I alluded to, would be completely normal. Next click. So my assessment, the BMDC score is normal for age, and she had the spine, the total body less head. Again, she's 14. I gave a comment about the technical quality. The technical quality of the study is good. L4 was deleted, however, from the final analysis due to the presence of an umbilical ring. Adolescents in general are not excited to take out that umbi ring. It would hurt to do so, and near impossible to get it back in. So when I see those, I generally just delete that vertebra that it involves. My general recommendations, the evaluation of risk factors for bone loss should continue. Would recommend optimizing calcium and vitamin D, and as appropriate, engaging in weight-bearing activity. So again, you want to give general statements because the clinician who ordered the DEXA scan should be giving the detailed recommendations. And then follow-up would consider a repeat BMD in 1 to 2 years if there's an ongoing threat to bone health, and the clinician can decide if there's signs of skeletal fragility. Next slide. All right, we've got another skeletal image. It's blurry, a little bit blurry there. That's a rate of change curve, but you don't need to see the numbers. So as you look at L1 to L4, there should be a progressive increase in absolute BMD. And I noticed there was a big jump from L3 to L4. It was inappropriately dense. Do one more click. And if we were together, it would say, why might that be? Well, lo and behold, it's another umbilical ring. It's a public health hazard, or maybe an ADEXA unit. It was actually really hard to see it. It was subtle on this skeletal image. But then when we went back to the patient, I talked to the clinician, she indeed had an MB ring, so it had to be excluded, similar to that patient in the report. So I just thought that was interesting, and just keeping it in mind. Next slide. All right, here's another quiz. So your patient has a T-score of -5. Is osteoporosis treatment needed? And so you see I've got the individual vertebrae, L1, L2, L3, L4. I've got different combinations, but was concerned because that combination I told you I preferred L1 to L4 was -5. I wish we were together so we could have fun with this. So next slide, please. No, you do not need to start treatment because this is a 5-year-old. And what did I tell you? Ignore those T-scores. So we're going to make sure we're using pediatric software. I think you can appreciate in the skeletal image, there's a little curve there. So she has a slight scoliosis. And when we do the L1 to L4, a Z-score is -0.7, so completely normal. And you can see here on the curve, the white line in the middle, that's the mean, plus or minus 2 standard deviations. And so this is completely normal for age. So just a way to remember that a T-score is not appropriate in a child. Next slide. The last case, and then I want to open it up for you all to share who you're seeing. At NIH, we see a lot of patients with rare diseases, and this is an active hospital. I am on call. In fact, I was on call last week for the pediatric endocrine service, and it's just like when I'm on call for an academic center. But what's different are the underlying diagnoses are fascinating, and we see so many patients with rare disease. And this was an example. So this was an adolescent, a 17-year-old with hyper IgE syndrome or Job syndrome, which involves a STAT3 mutation. So the 17-year-old adolescent girl presented to us. She had come back as part of a natural history study at the NIH Clinical Center after getting a first bisphosphonate infusion in the past. So her story, she has a history of 10 fractures since 2019, including 6 long bone fractures. 2 fractures required a open reduction, internal fixation, a right tib fib in 2022, and a left ulnar radial fracture in 2024. But interestingly, no fractures since receiving that first dose of IV zolendronate that was almost a year ago. So her story, as is classic for patients with Job, and I see so many of these patients because one of my colleagues is an expert. She presented at the age of 4 with abscesses, eczema, and signs of immunodeficiency, frequent infections. She received glucocorticoids between 7 and 12, which helped some of these children. She initially had a history of an allergy to milk, but outgrew that by around the age of 10. Intermittently was receiving calcium supplements, and is now consistently able to eat hard cheeses and yogurt, almost like a child with lactose intolerance. Is on supplemental vitamin D, 1,000 international units, supposed to be daily, but she was honest that she takes it 1 to 2 times a week, and she has a normal, regular menstrual cycle, and initiated her menses at an appropriate age. Next slide. So her laboratory workup, what was worried about all these fractures. So her thyroid function, free T4, TSH were normal, normal CBC, except she had elevated EOs consistent with her diagnosis. Got a Chem 10 panel, everything was normal, including calcium, mag, and phos. Her 25 OHD was 24 nanograms per ml, so above the 20 deficiency threshold, and would guess if she took her 1,000 IU supplement every day, we would get her even above 30. That might be a more optimal range. She had a normal PTH, but she had a slightly elevated calcium to creatinine spot ratio of 0.32. And the question was, she had taken some calcium supplements, probably worried that she was going to have labs measured, and she felt bad that she was forgetting her vitamin D and the intermittent calcium supplements. So we didn't quite know what to make of that. And her out phos was low for age. And the other bit of historical information, she had recently had spinal films that she brought in on a disc that showed mild scoliosis. Next slide. So she had DEXA scans. She had a bone age that was part of the natural history protocol at 17, interestingly was delayed at 15. And DEXA of the whole body was minus 2.5. She had a bone age adjustment of minus 2. And this had been done prior to my meeting her. Lumbar spine minus 2.1 for chronological age adjusted, minus 1.5. And then she had a VFA. We have the software to look at the lateral spine, and it's much less radiation than standard radiographs. And she had no in-plate deformities, but I was worried about her skeletal fragility given the number of fractures and how low she was still at that minus 2 threshold. Next slide. So Jobs and bone health, definitely a rare disease, 1 in a million live births. They can have hyperextensibility of joints. So this is another diagnosis beyond OI and Ehlers-Danlos that I've learned about since being at NIH. It's often quite common for them to have a low bone mass by DEXA and a tendency for fractures, especially as they get older, as we saw in this patient, older being into older adolescence, later in adolescence. Scoliosis has also been observed in many patients. The most common fractures are long bones and ribs. And STAT3 is a signal transducer and activator of transcription involved in immune function, plays a role in maturation of T and B cells. In inflammation, it's involved in the body's inflammatory response, particularly through its interaction with IL-6. Interesting, IL-6 is pro-inflammatory, but also pro-resorptive. And then in bone development, so STAT3 is important for inducing osteoblast differentiation and promoting bone growth and development. So one of my colleagues is tracking bone health and skeletal fragility, among other outcomes. And the Pediatric Endocrine Service, we have the opportunity to share in the wealth and learn about these patients with this rare disease and what it means for their skeleton. And Michael, I believe that's my last slide there. I just want to acknowledge my great team at NIH. I lead the Adolescent Bone Density and Body Composition Lab. These are my team members here, a staff scientist who's a PhD. I have 2 students, a research nurse, and my own DEXA and HRPQCT technologist, and we collaborate with many different institutes here at NIH using especially that HRPQCT scan. And then I have many collaborators in different institutes. So that is my last slide. I hope this overview was helpful. Oh, and these are my outside collaborators. Let's not forget them at many different hospitals, and have appreciated the collaborative work.
That's
Right.
absolutely great. We thank you tremendously. A wonderful talk. We have just a couple of minutes left. Does anyone want to ask a question?
Or to share a vignette of something that someone you're following that we could.
And Haley did follow up, which was important. Apparently, it is the newer machines. Can everyone see the chat? That it's not that they definitely cause trouble, but they haven't apparently verified that they don't interfere with medical devices. Isn't that?
Hallie, that's not what we wanted you to tell us.
Well,
but this is good to know.
Yeah, so we've just had to scan all those patients on our older scanners, but that's not always available.
Wow. No, really good to know. Yeah, it's interesting. We have a logic scanner. We have a clinical scanner, as clinical services here are doing clinical consults, and then we have a GE Lunar that's mostly used by obesity researchers for body composition. But that might be a workaround if you have another scanner somewhere. But I recognize that not everyone has that. Yeah, thank you again for all this information. I'll really look into this and discuss it with my colleagues.
All righty. So all my usual, I will not let Michael hang up and close the Zoom until you've had a few minutes to fill out your CME, because it's our one gift to you, and I don't want you to miss it. And I just want to thank everyone for attending, as always, and we'll look forward to seeing you next month. And Catherine, terrific. We thank you ever so much.
Thank you, Laura. Enjoy being here. Appreciated the good questions, and hope to be in the audience next month.